Hello, my name is Helen Pham, and today I'll be presenting on the article Low Molecular Weight Heparin Venous Thromboprophylaxis in Critically Ill Patients with Renal Dysfunction, a subgroup analysis of the PROTECT trial. The objectives of this presentation is to give an overview of venous thromboembolism and heparin, review the American Society of Hematology VTE prophylaxis guidelines 2018, and discuss the subgroup analysis of the PROTECT trial. Venous thromboembolism, also known as VTE, is when a blood clot forms in the vein. It affects about 300,000 to 600,000 Americans every year. It's the third most common vascular diagnosis after heart attack and stroke. There are two types of VTE, including deep vein thrombosis and pulmonary embolism. Deep vein thrombosis, also known as DVT, is when the clot forms in a deep vein, usually in the legs. It can also affect the arms or other parts of the veins. Symptoms of DVT include swelling of the leg, pain, tenderness, and even redness. Pulmonary embolism, also known as PE, occurs when the DVT clot breaks from a vein wall and then travels to the lungs where it can block some or even all of the blood supply. Symptoms of PE may include difficulty breathing, irregular heartbeat, syncope, or hemoptysis. So on this slide, I've listed the causes, risk factors, and complications relating to VTE. As you can see, many of the causes and risk factors are typically due to slow blood flow, pooling of blood, possible injuries, or clotting problems in the individual. For instance, in the causes section, you can see surgery, immobilization, hospitalization. These settings are where the patient isn't moving as much, and so there's going to be slow blood flow, which has an increased risk of blood clotting. Risk factors, you can see if you're older, if it's in your genes, if you're a long-term care patient, or if you travel long distance, then you're not moving as much either. So that causes higher risk of clots forming. And then complications of VTE may include, but not limited to, death, chronic pain, and skin ulcers. So the most current VTE prophylaxis guideline was published by the American Society of Hematology in 2018, stating that VTE is preventable with anticoagulants and mechanical measures. So in our acutely ill patients, the guideline recommends using unfractionated heparin, low molecular weight heparin, or fondaparinux rather than not using any of those agents at all. Between those three, they suggest using low molecular weight heparin or fondaparinux rather than using unfractionated heparin. And so the downside of the guideline is that there wasn't any certainty in VTE prophylaxis in critically ill medical patients with renal failure. Before we start talking about the journal article, I wanted to talk about heparin. So heparin is an anticoagulant, also known as a blood thinner, that prevents blood clot formation and stops further growth of current clots. Heparin's mechanism of action is to potentiate the effects of antithrombin 3 and inactivate thrombin or factor 2 and factor 10 to prevent conversion of fibrinogen to fibrin. Overall, heparin is a fast-acting anticoagulant that binds to these factors and prevents clot formation. In people with medical conditions, undergoing medical procedures, or have high risk of clot formation, heparin is a good agent to use. For instance, heparin can be used in small amounts to prevent blood clots from forming in catheters left in veins over a period of time. Here I've listed some of the adverse events for heparin, including heparin-induced thrombocytopenia, bleeding, and bruising. I wanted to talk a little bit about the heparin-induced thrombocytopenia. It has two types. Type 1 hit is when there is a slight fall in the patient's platelet count. It typically occurs within the first 2 days after administering heparin. This type does not have any consequences, so heparin may be continued. However, if a patient is experiencing type 2 heparin-induced thrombocytopenia, there's going to be a large fall in platelet count within 1 to 7 days after heparin administration. And so type 2 is an immune response to the heparin complex with the blood factor platelet factor 4 or PF4. So when the antibodies identify this complex as a foreign object, it will bind to the complex and destroy the platelets. The antibodies and the factor 4 will then activate more platelets, which will lead to more clots. And with more platelets being used, there will be a low platelet count. And so with the destruction of platelet, that can lead to the formation of new blood clots in the patient and resulting in DVT. So when a patient has heparin-induced thrombocytopenia type 2, heparin needs to be stopped, but they still need to be anticoagulated, so we need to use a direct thrombin inhibitor such as argatroban. Type 2 is actually less common than type 1, so we need to make sure to monitor the patient and make sure that heparin is discontinued when necessary. The metabolism and clearance of heparin includes the liver, the kidney, and the reticuloendothelial system. Contraindication to heparin is if the patient has a history of heparin-induced thrombocytopenia. There are two types of heparin, including unfractionated heparin and low molecular weight heparin, which we will talk about later. And the reversal agent for heparin is protamine. Protamine basically neutralizes the effect of heparin with ionic bonds to form a salt aggregate. This complex is inactive and has no anticoagulant properties, and so it's broken down by the reticuloendothelial system. Protamine works within about 5 minutes and has a short half-life of 10 minutes. Here I have the two types of heparin, unfractionated heparin on the left and low molecular weight heparin on the right. On the left, unfractionated heparin inhibits both factor 10A and factor 2A, which is thrombin. It's IV administered, so it works immediately. It has a higher risk of heparin-induced thrombocytopenia. It has a lower cost. It's primarily excreted by the reticuloendothelial system, has a half-life of 1.5 hours, and you have to monitor the activated partial thromboplastin clotting time. On the right, we have the low molecular weight heparin. It's a heterogeneous collection of heparin molecules, so the average molecular weight is going to be lower than the unfractionated heparin. It's not as effective at inhibiting factor 2A as unfractionated heparin is. It's subcutaneously administered. It has a longer half-life. It costs more. It's mainly renal excreted. It has a half-life of 2 to 7 hours, and you have to monitor the anti-10A. Here I have an image of the two types of heparin with antithrombin. So on top, we have unfractionated heparin binding onto the antithrombin, where it can then bind onto factor 10A or thrombin. On the bottom half of the image, we can see that low molecular weight heparin binds onto antithrombin and binds mostly to factor 10A. This is due to the fact that unfractionated heparin is longer, so it can bind onto thrombin and hold onto it. So for our journal article, we're going to relate to PROTECT, or the Prophylaxis for Thromboembolism in Critical Care Trial. It was a pilot study that was published in December 2005, where the primary objective was to determine the feasibility of performing a large randomized trial with low molecular weight heparin and unfractionated heparin for efficacy in VTE. The conclusion of the pilot study was that multi-center randomized clinical trial with both heparins in ICU patient is feasible. Now for our journal article, the subgroup analysis of the PROTECT trial. It was published in 2018. The purpose of this trial was to look at the subgroup analysis for the comparison of low molecular weight heparin dalteparin and unfractionated heparin for VTE prophylaxis in critically ill patients. The primary objective is to compare the efficacy and safety of dalteparin with unfractionated heparin in patients with dialysis-dependent ESRD or end-stage renal disease before ICU admission. Secondary objective is to conduct the same comparison in patients with a broader spectrum of renal impairment, including those with dialysis-dependent ESRD or creatinine clearance of less than 30 mL per minute without dialysis. For the background, ICU patients are at high risk for developing VTE, including DVT and PE. Despite unfractionated heparin prophylaxis, 5% of patients still develop proximal DVT. Low molecular weight can be an agent to consider for these patients because benefits can include daily dosing, pre-filled syringes, and lower incidence of heparin-induced thrombocytopenia. The main downside of low molecular weight heparin is that it's mainly cleared by the kidney. However, a pilot study of about 19 ICU renally impaired patients and a multi-centered prospective cohort study of 138 ICU renally impaired patients showed that bioaccumulation of prophylactic low molecular heparin was not observed. One thing we need to consider is that we want to avoid therapeutic doses of low molecular weight heparin for VTE treatment in patients with severe renal dysfunction, and those doses may include dalteparin 12,000 to 18,000 units daily. However, you can consider prophylactic doses of low molecular weight, including dalteparin 5,000 units daily, because small observational studies have seen no bioaccumulations occurring between 7 to 10 days of treatment. There are no previous studies that have assessed VTE prophylaxis between low molecular weight heparin and unfractionated heparin. So the journal article that we'll be focusing on is funded by these three organizations. For the methods, the study design and methodology of the PROTECT study was a multi-centered randomized blinded control trial. It compared the low molecular weight heparin dalteparin to unfractionated heparin for the prevention of VTE in critically ill ICU patients. The stratified randomization was based on the type of admission, either medical versus surgical, and the center that they were in, which included 131 hospitals. Research pharmacists prepared the study interventions, which were in identical syringes, and those that received the low molecular weight heparin dalteparin also received a placebo syringe daily to parallel the unfractionated heparin group, which were administered twice daily. Continuing with the methods, study interventions included low molecular weight heparin. This includes dalteparin 5,000 IU daily with placebo daily, and unfractionated heparin 5,000 units twice daily. For the outcomes, our primary outcome will be proximal leg DVT, and secondary outcomes include major bleeding, PE, and any VTE. For statistical analysis, the VTE incidences and major bleeding are based on the groups that the patients were placed in. So it would be ESRD patients versus patients with no ESRDs, and then severe renal dysfunction patients versus those with no severe renal dysfunction. And so the Cox regression analysis was used to obtain the hazard ratios, the 95% confidence interval, and p-values for the effect of dalteparin versus unfractionated heparin. For our study patients, I've listed the inclusions and exclusions. For the inclusions, they need to be over or equal to the age of 18. Their body weight is greater than 45 kilos. They have expected ICU length of stay for more than 72 hours. The patient has an initial creatinine clearance of less than 30, but they also would have had renal function improvement during the ICU stay. For the exclusion, that would include major trauma, neurosurgery, orthopedic surgery, whether they've had it or they're anticipating on getting these surgeries, the need for therapeutic anticoagulation, unfractionated heparin administration in the ICU for 3 days, contraindication to heparin or blood products, if the patient is pregnant, if they have life support limitation, enrollment in the related trial, so if they're already enrolled in a trial that's similar to this one, if the patient has a creatinine clearance of greater than 30, greater than or equal to 30, and developed worsening renal function during the ICU stay. For the results, the enrollment and baseline characteristics are listed below. 3,746 patients were involved in the intention to treat analysis, which means that we involved all the participants who were randomized regardless of the treatment they received. half of the patient received dalteparin and the other half received unfractionated heparin. Of the 3,746 patients, 118 were end-stage renal disease patients with mean age of 63 years of age and 39% female. 590 included those who were ESRD and those who had creatinine clearance of less than 30 and are not on dialysis. Those that are not on dialysis had a mean age of 69 years of age and 46% female. And then 3,089 had a creatinine clearance of greater than or equal to 30. As you can see, there was a greater amount of patients who don't have severe renal dysfunction involved in the study. And so the median duration of DVT prophylaxis was 7 days. 4 to 12 days was the range. And then majority of the patients were medically admitted on mechanical ventilators and central venous catheterization. Here's a table in the article where it lists the patient's characteristics. I've highlighted the ones that I mentioned. So majority of the patients were medically admitted, were on mechanical ventilator and central venous catheterized. So those were the three that I've noticed that were similar with the patients. For the result, our primary outcome, remember, was the proximal lake DVT. We split it into two different groups. For the baseline end-stage renal disease patients, there was no significant difference between those who received dalteparin and unfractionated heparin for the incidence of proximal DVT. The p-value was 0.76. For those in the severe renal dysfunction, those with ESRD or creatinine clearance of less than 30 without dialysis dependence, there was a significant increased risk of proximal DVT in patients who received dalteparin compared to unfractionated heparin, with a p-value of 0.04. For the secondary outcome, we look at major bleeds, any VTE, or PE. So for the baseline end-stage renal disease patients, there was no significant difference between those who received dalteparin and unfractionated heparin for major bleeds or any VTE. However, patients with no end-stage renal disease had a significantly lower risk of PE with dalteparin, with a p-value of 0.01. Severe renal dysfunction patients, there was no significant increase between the patients who received dalteparin and unfractionated heparin for any VTE, with a p-value of 0.07. There was no significant difference between patients who received dalteparin and unfractionated heparin for PEs, with a p-value of 0.39, or major bleeds with a value of 0.66. Patients with no severe renal dysfunction have a significantly lower incidence for any VTE with dalteparin, with a p-value of 0.04, and any PE with a p-value of 0.02. For the safety results, end-stage renal disease had no significant difference between dalteparin and unfractionated heparin for any VTE and major bleed outcomes. For those in the severe renal dysfunction, there was no significant difference between the dalteparin and unfractionated heparin for any VTE and major bleed outcomes. For the author's conclusion of the article, in critically ill patients with dialysis-dependent ESRD at baseline, there was no significant difference in proximal DVT, any VTE, or major bleeding between those who took dalteparin compared to unfractionated heparin. In a post hoc analysis of patients with severe renal dysfunction, there was no significant difference in major bleeding between those in dalteparin and unfractionated heparin group. However, patients who received dalteparin had a non-significant increased risk of any VTE and a significantly increased risk of proximal DVT. Low-dose dalteparin, when administered over a 7 to 10 day period, appears safe for use in patients with ESRD or creatinine clearance of less than 30 without dialysis dependence. For the conclusion, the authors listed strengths and limitations. For the strengths, it was the largest study with patients in end-stage renal disease who received low molecular weight for VTE prophylaxis, and it also incorporated placebo to parallel the twice dosing strategy for unfractionated heparin. Limitations included numbers of end-stage renal disease patients were relatively small compared to the entire study sample. The mean duration of anticoagulant prophylaxis was 7 days, so results may not be applicable to patients who received a longer duration for prophylaxis, and the study did not consider the efficacy and safety of low molecular weight heparin other than dalteparin. In the discussion, the author wanted to mention that in the end-stage renal disease patients, there was no significant difference in the rate of proximal DVT. However, for those in the severe renal dysfunction group, there was a significantly higher rate of proximal DVT in those who had dalteparin compared to the unfractionated heparin. The author wanted to give some reasonings for these results. So numerically, there were higher major bleed events in the unfractionated heparin group, and that is maybe due to that unfractionated heparin may be more effective in anticoagulant effect over dalteparin. It is also unlikely for unfractionated heparin to bioaccumulate due to the fact that it's mainly cleared non-renally, and there is more persistent antithrombotic effect with twice daily dosing compared to the once daily dosing with dalteparin. However, that doesn't explain why in the end-stage renal disease patient there was no significant difference, but then in the severe renal dysfunction group there was a significantly higher rate. And so it could be due to chances, because even though these were the results, the severe renal dysfunction subgroup only represented 16% of the study population. So this article can impact patient care because it does challenge the premises that low molecular weight should be avoided in patients with renal dysfunction just because of the pre-assumed bioaccumulation and potential increase in bleeds. However, as you can see the results, it does show that there is potential therapeutic options with low molecular weight heparin for the use in thromboembolism prophylaxis. To end the discussion, further study is required before any definitive conclusions may be made with the efficacy and safety of low molecular weight heparin, including dalteparin, compared with unfractionated heparin for the prevention of proximal DVT in patients with severe renal dysfunction. For Navicent, the hospital that I'm currently at, I would continue with a current protocol with the use of either unfractionated heparin or Lovenox. Although this study shows no significant differences in any VTE or major bleeding between unfractionated heparin and dalteparin, more studies should be performed to determine the efficacy and safety of dalteparin and other low molecular weight heparin, including enoxaparin, tenazaparin, for thromboprophylaxis. And here are my references. Thank you.